Okay, so this is diagnostic sheath. This is obturator. This is sheath. Sheath has only inflow, so diagnostic sheath doesn't have outflow. Okay, and obturator is used to store the sheath. So can you see these two lines, 1, 2? So whenever you lock it like this. To open the lock, you have to align it, and when you want to introduce the obturator, you can see there is one notch here on the obturator. So can you see this notch here?
Yes.
So you have to align 1, 2 and 3, then only it will get locked. Then rotate this, so it is locked now. So obturator is used to store the sheath so that the tip doesn't bend, otherwise it will injure the uterus. Understood about this? Now this is operative sheath. Okay, so operative sheath has inner sheath and outer sheath. So now first inner sheath. Inner sheath has inflow for normal saline or glycine, but for operative sheath we don't use glycine. Glycine we use for resectoscope, monopolar, right? So this is for normal saline. This is operative channel to introduce the operative instrument like scissors, graspers, other instruments, and this is the channel for scope. Then this is outer sheath. Outer sheath has outflow. So the fluid inside the uterine cavity is collected by these holes, and then it comes out through outflow. Okay. Now here notice that there are 3 channels here, but here you can see only 2 channels. So lower one is for hysteroscope, upper one is for operative instrument as well as for fluid. So remember, whenever you are doing diagnostic scopy with operative sheath, the distension is good inside the uterine cavity. But as soon as you introduce the operative instrument, the flow decreases, and then the pressure inside the uterus also decreases because of inflow reduction, and then uterine cavity will reduce in the size. Understood? So that is why whenever we are introducing the operative instrument, I tell my assistant to increase the pressure a bit more. Understood? Because upper channel is shared by both. You will notice whenever you are doing diagnostic scopy, there is good distension of the uterine cavity. As soon as you introduce the cannulation wire or some instrument, the uterine cavity deflates. Okay, so remember that. How do we assemble? So you can see now the darwaza lavla hai na? You can see there is the notch here, notch here, and you can see there is notch here. Can you see this? There are always markers. You can see the notch here, notch here. So these are the notch. So whenever you are inserting the inner sheath into outer sheath, you have to align the line and notch together. Okay, so this fits and then rotate, so it locks. Understood? This is one point. Second point, in operative sheath, the inflow and outflow are opposite to each other. Can you see this? Inflow and outflow are opposite to each other. Third point, inflow is close to you. Outflow is away from you. Can you see this? Inflow is close to me, outflow is away. Any doubt about this? Easy to understand instrument, easy to understand locking mechanism. Again, whenever you will introduce the scope inside, there is a notch on the scope also. Yes, you have to align the notch on the scope to the notch here on the instrument, and then it fits into and then rotate. You want to see this? Same, both the instruments are same. Only thing, this is 4 millimeters, this is 2.9 millimeters. Yeah. So this is inner sheath, no? So you have to remove this outer sheath. So yes, anti-clockwise. Whenever you are removing something, anti-clockwise. Remember always. Huh? Yes. Pull. Unlock first. Unlock everything. See, for unlocking, what I told. See, if lock is half open, it will not come out. You have to completely open the lock. Completely open. See, this is complete open. Huh? Once you completely open the notch, it will come out. Understood? It's very easy, not difficult at all. Try once again. Yes. Okay? Just slide in and lock it. Very important to know your instruments. If you know your instruments properly, then you can use it effectively, and second thing, you will not damage them. These are very delicate instruments. At the same time, they are very costly as well. So use them carefully. Understood? Understood? So this was operative sheath. Now the third instrument is resectoscope. Okay, keep it down now. Any questions about this? Operative sheath? Nothing. Now resectoscope. Now there are two types of resectoscopes. First we will understand about the parts of resectoscope, and then I will tell you about two types of resectoscopes. So again, resectoscope has outer sheath. Okay, hold this. See, outer sheath. Now operative sheath, outer sheath was having only outflow. This outer sheath is having both inflow and outflow. This is the difference. Got it? Second, understood that? Again, it has holes for collecting fluid. Understood about outer sheath? There is nothing else. Now this is inner sheath. Now inner sheath doesn't have anything. No inflow, no outflow. You look at the inner sheath tip, ceramic coated, insulated, so that the electricity which you are using inside the cavity should not get transferred to the instrument. Got it? So insulation, ceramic coating. Understood both the parts? Then this is third one, or you can say this is third one, operative element, working element. Okay, and this is the electrode. So electrodes are like, this is loop electrode. Can you see this? Loop. Then there are different types of Collins knife is also there. So if you want to resect the polyp, you will use loop electrode. If you want to do septum resection, you will use knife, Collins knife. If you want to ablate the endometrium, you will use roller ball. So there are different types of electrodes which you use according to the surgery you are planning. See, this is roller ball. This is for ablation of the endometrium wall. This is for polypectomy. Knife hai? This is, see, this is Collins knife. Got it? knife, this is blunt. Yeah. Okay. Understood about the parts? Then
you can change this one.
yeah, you can change whatever you want. If you want to do polypectomy, use this. Then change to Collins knife for septum resection. Then change to roller bore for endometrial ablation. Yeah. These things remains the same. Only thing changes is electrode. So this is working element. Okay. Any doubt about this instruments? No. Keep it down. Keep it here. Now, the most important part of resectoscope is working element. I will tell you how to assemble that also. But you can see here, my thumb is moving. Okay. So there are two types of working elements. In one type, thumb moves. In second type, finger moves. Here fingers are constant. Can you see this? Here if you see, what is moving? Fingers are moving. So this is thumb operated, this is finger operated. Understood? So in gynecology, we want thumb operated, not finger operated. Because in finger operated, the electrode remains outside. See? In thumb operated, electrode remains inside. This is the difference between these two electrodes, these two resectoscopes. Now I will show you about this also. Again, same. I'll tell you. Just understand the instrument first, then I will tell you the differences between two. So this is a slightly larger one than this. So resectoscope comes in different sizes, ranging from 16 French to 26 French. So this is 18 French one, 18 French, and this is 26 French. So this is smaller, this is larger. Okay. So again, like that, the outer sheath is having inflow and outflow both. So which is inflow, which is outflow? Yeah, arrow, but the closer one is inflow. Close to you, if you hold it like this, close to you is inflow always. Away is outflow. And then there are arrows and everything is there. Again there are series here, holes. Now see, every instrument will come with different locking mechanisms. Some are with pushing, some are rotating. So you have to understand your instruments, right? So here it is rotating. Here it was button type. This is inner sheath. Again, same like that with ceramic coating. Correct? Loop. This is electrode. So Collins knife. Okay? And this is working element, finger operated. Understood the difference? Difference in size and difference in operating mechanism. Now how do we assemble? First, introduce the scope carefully under vision. Then take this loop. Can you see this channel here? See, it goes like in here, and then you have to just push it. Click. So it is locked now. When you want to take it out, press this button here. It will come out. Okay? Try once. Take it out and lock it. Because understanding instruments are very important. Yes. Right? Yes, good. Give it to her. Do it once. Press. Take it out. Very delicate, very delicate. That is why I am asking you to lock, unlock, use it so that you understand how delicate it is. See, now this is training center. You need to learn proper techniques here. If you try to learn on your own instrument, there are chances that you might break them, damage them. So it is better you learn under my supervision. Lock, unlock. This is the only difficult part. Okay, rest of the things are very easy, very easy. Click came.
Yes.
Okay, now give it to me. Yes, huh? Then take the inner sheath. Where is the inner sheath? This is the inner sheath, right? So just take the inner sheath and go in. Now again, there are markers on every sheath. So what are the markers here? Actually, markers are gone. This is old sheath, like I'm using it since 10 years. So this was the first sheath I bought, 26 French. So see now, this is the locking mechanism. Can you see the marker here? Dot. So there will be notch, there will be dot, whatever it is. I am not using this sheath regularly, that's why I forgot what is there, but you can see the dots. There will be some marker on every sheath. Then align that marker to this. They have given this here. Can you see this?
Yes.
Lock. See, lock it yourself. Easy? Easy, not difficult at all. You have to see for the markers. Now, whichever company hysteroscope you purchase, you know your instruments. Like you might purchase some other company hysteroscope which is having some different markers. So you should know the markers given by your company. Yeah, full lock. Lock means full. Don't use force until it goes. That's it. It is not going beyond that, means it's done. Got it? And then comes the outer sheath. So now can you put the outer sheath? Use your brain and then assemble the outer sheath. Use your brain. Done? So there was a, yeah? So that's what I am telling you. Sometimes there are buttons. So now here there are two different locking mechanisms. Outer sheath locks to inner sheath by button. See?
Yes.
But inner sheath locks with the operative instrument with this rotating channel. So that is why I told you have to understand. Now about this. This is 18 French.
So in this the telescope.
Yeah, from here. It will go from here. Telescope will go from here, right? Now.
So, but from there it is visible here. Because
it
middle this instrument is there. So from there.
No. It will come in between.
In between.
Yeah, in between, because this instrument is outside. That is the difference between this sheath and that sheath. So it will be here. So through scope, आहे का 4mm scope? आहे? घेऊन ये. I will show you in the camera itself. So how it looks. Or if you want, I can show you right now also. you have to actually, whenever you are inserting the scope, you have to insert the scope first, slowly, under vision. You can see the notch on the scope. You can see the line here. Lock. Okay. Lock. Okay. See how scope comes. Can you see that? And then after putting the scope, you can go in slowly. Very slowly you have to do everything, and then lock. This assembly is ready now. Correct? So keep it here. Now about the 18 French one. So this is working element. So now difference between this working element and this working element, one more difference is there. If you see, shall I remove the scope now? If you have understood. So tune there. Handle scopes very delicately. Now you can see there are some differences. The loop is same, almost same, but this loop is having only this notch. See, this is having the pipe. The pipe is here. The pipe of this resectoscope is on the working element itself. You're getting my point? Huh? So, yes. So, कुठे आहे रे याचं? खाली आहे ना? हाँ, sorry, I was inserting from reverse side. So this is, can you see the two holes? Huh? So this will go in upper or lower? Lower? Yes. Yes, lower one, because this is smaller one. So lock. Press this and take it out. This is the most important thing, otherwise the rest of the things are very easy. Slowly, slowly. Correct? Now tell me, just give it to me. Now tell me, it will be like this or like this? Up, because the scope will go inside. So this confusion is there in this resectoscope, whether to keep it up or down. In this resectoscope there is no confusion because all these pipes are attached to working elements. Understood the difference between two working elements? See, these are two working elements. Additional thing is these pipes. Once you attach this, as I told you, scope ahe. Now this scope 2.9 is very delicate. You have to use it very carefully. Very carefully. So now this scope will go slowly inside this. So this is the problem with this kind of sheath, that the scope zoom karna. This is very important to understand. If you push it forcefully, scope can hit this and get damaged. So that is why it is very important for you to align the scope properly. Understood? While inserting. So these things are to be done very, very carefully. I myself also doesn't do all these things because I have trained these people. They do it carefully for me because we are sometimes in hurry. We want to finish procedure fast. We want to see OPD. So we might end up doing it fast and damaging it. So that is why I don't handle all these things. We have dedicated people. So you should also train your people. Initially for 1 or 2 years you handle yourself because you know its value. They might damage it, but once they are trained, let them handle it because they have time, you don't have that much of time. Understood the problem, what can go wrong? Many people have. So the problem what happens, if you don't insert the scope at this stage, what many people do, this is inner sheath, this is outer sheath, right? So you insert, this is easy now. Now I think you have understood. Can you see this arrow?
Yes.
Can you see the arrow on this?
Yes.
So just engage, press this, this is locked. What mistake people do is, they first assemble this and then insert the scope.
It's not under vision.
Not under vision, and it can hit. So that is the precaution you have to take. In this, you can assemble everything and then you can put the scope. Nothing will happen because there is no gap between working element and this pipe. But there is a gap between working element and the pipe in this resectoscope. Understand the difference. That is why it is very, very, very important to introduce the scope under vision and then engage inner and outer sheaths. Got it? Any doubt about this? I think everything is clear now. If you want to assemble, disassemble, you can do that one more time. Then we will go on the okay. हा स्कोप ठेवून दे आता. हा स्कोप आणि तो रिसेक्टोस्कोप ठेवून दे. Do you have any doubt? Or you understood? Understood? Easiest method is what you know. First engage outer sheath and inner sheath, and then hello. बोल ना विशाल, बोल विशाल बोल. नाही रे, नाही. लावून दे मला. Doubt? Any doubt? So you should separately attach inner sheath and outer sheath and then this introduce into this. So this will be easy for you to do. So first thing to introduce is attach the electrode to working element, then introduce the scope under vision, attach inner sheath to outer sheath, and then attach both the things together. This is the flow, workflow. Yeah, this is how. Notch. You have to align. There will be arrows, match arrows. No arrows? First ऐसे करो ना, देखो ना. Correct? Now press. No. Not like that. You have to while engaging also press. Correct? This is thumb operated. Okay.
For the thumb operated one, you have to introduce a scope combination. Here the problem is with the scope.
Yes.
That is easily inside the scope.
So don't remember that thumb operated one and that one. These are the companies who makes the instruments like this.
It is the only difference is the
Companies are different. That is why they have made. Yeah.
Otherwise, there is no.
So you have to know your sheath. What type of sheath it is. What type of attachment is there. Yes. Look. For hysteroscopic myomectomy also. Correct? Any doubt in instruments? I think you have understood everything now. So what we saw, we will just revise: diagnostic sheath, then operative sheath, and then resectoscope. Diagnostic sheath has only inflow, operative sheath has inflow, outflow, operative channel, and then this resectoscope. Now about distension media. So distension media used for diagnostic hysteroscopy and operative hysteroscopy without electricity is normal saline. Then when you are using resectoscope, depending on which type of resectoscope you have, monopolar or bipolar, the distension media will change. If you have bipolar resectoscope, you will use normal saline as distension media. So same distension media which you are using for diagnostic can be continued for operative. But if you have monopolar resectoscope, you need to change the distension media. Change it to glycine, which is most commonly used. Remember only this. Now this is monopolar. And this is bipolar. So which distension media is used when you use that? Glycine. And with this, normal saline. Okay. Now how much pressure? So clear about distension media. Now how much pressure is required to distend the uterine cavity? Why do we use distension media? To distend the uterine cavity. So how much pressure is required? Like in laparoscopy, we use 14 mm of mercury. In hysteroscopy, more than 45 millimeters. More than 45 millimeters of mercury, because uterus is a muscular organ. So it requires some pressure to distend it. More than 45 millimeters of mercury is required. So we usually set the hysteromat pressure between 45 to 95. 95 is mean arterial pressure. Got it? So whenever I am doing hysteroscopy, I will set between these two depending on the leak, patulous os. So whenever you are introducing the hysteroscope, if you are getting distension at 60 pressure, it's okay, no need to increase. But if you have kept pressure 60 and still the uterine cavity is not distending, that means the hysteromat is showing 60, but there is some leak because of which the inside pressure is not 60. Because if inside pressure is 60, uterus will distend. As uterus is not distending, that means inside pressure is not 60. So what we tell our assistant, increase the pressure on hysteromat so that more fluid will come and it will distend the uterine cavity. The moment you see uterine cavity distended, you ask your assistant to stop now, stop there. So sometimes the pressure required to distend the uterine cavity is 60, sometimes it is 70, sometimes it is 80. Sometimes I ask my assistant to increase more than 95 also, 110, 120. Why? Because there is lot of fluid which is leaking out and I am not getting adequate distension. So as I am not getting adequate distension, you can ask your assistant to increase, because even though the machine is showing 120, inside pressure is not 120. So you are not supposed to worry. You got the difference between the machine pressure and inside pressure. If uterine cavity is distended, then you don't ask your assistant to increase the pressure. Clear? No confusion?
Yes.
What confusion? You can ask me everything.
Machine pressure and inside you.
See, now understand one thing. Machine is used to give you normal saline with some flow rate. That normal saline is going inside the uterine cavity and increasing the pressure. Understood? So you have to set the pressure on the machine, like you set the pressure on the CO2 insufflator. Like we keep 14 pressure. Then what happens? The CO2 goes in, and once the inside pressure goes to 14, the CO2 inflow will stop. Similarly, in Hysteromat, once you set the pressure to 60, the normal saline will go in and start inflating the uterine cavity. But at 40, the normal saline is coming at particular flow rate. Whatever fluid is coming inside the uterine cavity, half of the fluid is going out through cervix. So it is not able to increase the pressure till 60. That is why uterine cavity is not distending.
Yes.
If there is no leak, then the 60 will match this 60.
Yes.
But if there is leak, the both pressures will not match. This is practical point.
Yes.
So what you can do in such scenarios? Increase the pressure, or you can attach the Ellis forceps to the cervix so that it doesn't leak. Sometimes in spite of increasing so much of pressure, still you will not get distension. So attach the Ellis forceps to cervix and then introduce the hysteroscope in the middle. Now clear?
Yes.
Shall I repeat one more time? No? Is it clear now? Because to understand this is very important. Clear?
Yes.
About fluid?
Yes.
Clear about Hysteromat?
Yes.
Clear about scopes?
Yes.
Two types of scopes, 2.9 mm and 4 mm. 4 mm is standard, 2.9 is office. Other types are flexible scopes and less diameter scopes, 1.8, 1.9 mm. They are very delicate. I don't personally use it. You can use them. Now we will go to the hysteroscopy model now. Sure. Come here. Now here this is the uterus and we will do hysteroscopy in this, and I will teach you about the basics. Now suppose there is one patient who has come to you for diagnostic hysteroscopy. So now for diagnostic hysteroscopy, Shubham, हे जरा तिकडे ठेवतो का? For diagnostic hysteroscopy, obviously you will think that I will use diagnostic sheath, correct? So this is the diagnostic sheath we are using for diagnostic scopy. So take out the obturator. Take out the obturator and insert the scope. Lock it. Shubham, camera देवा. Zoom करून ठेव याच्यावरती हा. तिकडे ठेवतो का? तिकडे ठेवतो का? तिकडे ठेव. You have to be very careful when you are using instruments. They are very delicate. Now this is the camera. We attach it like this. This is the light source. Okay, and the fluid will come from above like you did it yesterday.
Yes.
So always remember, whenever you are holding a hysteroscope, you should hold it in this manner. This manner means the camera head should be facing the up. You cannot tilt this. If you tilt this, then the picture will tilt. So always remember, camera head should face up. The movement of camera head will not be like this. It will be only in horizontal planes. Got this?
Yes. Yes.
Remember this. This is very important. Second thing, light cable will always come from below. Like sun rises from below to up. For remembering purpose. Normal saline will come from above. It's like raining from above. Clear about this? Now hold it in such manner. Now you will go into the cervical os. Can you see the cervical os there?
Yes.
Yes. Now can you see the notch? Please show me the notch on the screen. Yes, that is the notch. Now the whole game of hysteroscopy is around that notch. How? Whenever you are going inside the uterine cavity, if the notch is not aligned to the opening, then your hysteroscope will not move. See? It will move here because this is a soft model, but inside the uterus you will go into the cervical tissue. See, like this. So the trick here is you need to align the notch to the cavity. Is it aligned now?
Yes.
Yes? Now you can smoothly go in. This is the trick of doing hysteroscopy. Whenever you see me doing hysteroscopy, you will see I will never go like this. I will always align the notch to the opening and I will start going in. You got this?
Yes.
Clear? This is very important. Now once you are going inside the uterine cavity, first thing is to examine the TV चालू आहे ना. First एकदम zoom in करून घे चांगला, TV कडे घे. First thing is to examine the endocervical canal. Now when you are examining the endocervical canal, you should not see, there is no need to align the notch. So see, you can examine the endocervical canal in panoramic view. This is the panoramic view,
Yes.
isn't it?
Yes.
Clear?
Yes.
Now if you want to see the right side of the endocervical canal, this is the way to see it. If you want to see the left side, this is how you see it. Upper side and then lower side. Is it clear?
Yes.
Because this is 30 degree. So after examining the endocervical canal, you slowly align this notch to the opening and slide the hysteroscope in. This is the internal os. Correct? Once you are into the internal os, what you see is anterior surface of the uterus. This is anterior because light cable is below. So you see anterior. So just go in, see the anterior, go fundus, and now see what I am doing. I am taking my hand up so that the scope inside goes down. See. Got this?
Yes.
So this is the panoramic view now, and I can see both the osteas from here. Can you see the both the osteas? Yes? I'll show you, but you can see those holes,
Yes.
right? So now this is panoramic view in which you are able to see the anterior wall, posterior wall, fundus, slightly left and slightly right. Correct? Now again you go in, examine the anterior wall, come back, rotate the scope, examine the lateral wall, come up, examine the posterior wall, again go on the left side and examine the left lateral wall. This is how we examine everything. Go close to the ostia, examine the left ostia, go close to the right ostia, examine the right ostia. This is how we do the diagnostic scopy with the help of diagnostic sheath. Now the problem when you use diagnostic sheath is Whenever there is blood or mucus collection inside the uterine cavity, there is no channel to drain it out. Then the picture becomes blur, hazy. There comes the advantage of operative sheath. So that is the reason I never do diagnostic hysteroscopy with diagnostic sheath. I prefer operative sheath instead of diagnostic sheath, because operative sheath has outflow. Most of the times there is some blood inside the uterine cavity, some mucus inside the uterine cavity. So once you open the outlet, dirty fluid will come out and then normal saline will fill in the cavity. You can see the clear picture. Are you convinced with that?
Yes.
So I most of the time suggest my fellows not to purchase only diagnostic sheath. Why to purchase unnecessarily if you are not going to use it? Okay, and the advantage of 2.9 mm operative sheath is it also doesn't require dilatation. So without dilatation you can go in, right? I hope you understood now. Now we will change the diagnostic sheath to operative sheath. Again, for that, here, camera dhar. See, for hysteroscopy, you need assistants who can help you properly, who understand how delicate the things are. Now I'll keep the sheath here and we will use the operative sheath. I'm delicately, carefully putting in the scope inside.
Align.
2 dots, notch, align, done. This is the camera. The assembly is same. The assembly is same. Again, the light cable will go from below. इकडे दाखवतो का जरा एकदा आलं. This is how now the camera.
So that resectoscope can be introduced to this.
No, resectoscope no.
Or that energy.
No, energy. This is not for energy. This is operative sheath.
Operative.
This is not resectoscope. This is non-energy.
Non-energy.
This is non-energy. For scissors, graspers. आहे ना, scissor grasper कुठे? Okay. Yeah. So now again hold it like this. Light cable, camera, normal saline, outflow. The assembly is clear. Go inside. Cervical canal. Can you see now? Okay. Align the notch. Go in slowly. Go in slowly. Okay. Anterior wall. Then take it up. Have the panoramic view and then go in. Correct? Examine all over. And then suppose there is some pathology inside. What pathology you want? Polyp. Then how you resect the polyp? See, you can resect the polyp with scissors also. If it is a small polyp like 0.5 centimeter polyp or 1 centimeter polyp. Guys, the instrument is okay. So you can do it with scissors also. Every time you doesn't need a resectoscope. If the patient is infertility, I would recommend you to use cold scissors in spite of resectoscope for doing the operative hysteroscopy, right? Suppose there is polyp. So what I will do is, I will introduce the scissors from here. See, you need assistant. Kharab zale re. See, these are very delicate, so most of the fellows damage this. So we don't replace it because these are very costly. So this is just for mimicking. So remember, so my assistant, I will be holding this and this. My assistant will guide me. Chalo, guide me. दाखवतो का बाहेर इथे? चालू आहे ना? हां. आता open the notch. Knob भी open करो ना. Yes, it is closed. Now it is opened. Now it will go in. If you keep it open, the fluid will come out. Correct? Now it is open. Now see, my scissor will go. Right? It is going in. Now suppose there is a polyp here, you can do polypectomy. You want to cut the septum. Clear? Suppose you want to do the cannulation on the left side. Okay? You have to go near the ostia and stay like this. And then introduce the cannulation wire through the operative channel. Now stay constant here, and now tell me from where the cannulation will come inside. Tell me the area. Tell me the area. No. Tell me the area. Opposite to the notch. See? Understood? Opposite to the notch. Opposite to the light cable. So again, once it goes here, you have to align everything. See? And then slowly go into the ostia. You understood this? Huh? Correct? The cannulation wire will go like this. So you don't have to pass cannulation wire through and through. You just go and stay near the ostia and then push the fluid. With hydrodissection, it will go. Suppose there is any flimsy block, it will be cleared. Right? You understood about this?
Yes.
Sometimes there are flimsy adhesions on the ostia, so you can introduce the scissors and just cut the flimsy adhesions. Whatever things you want to do, you can do with the scissors. You want to do the metroplasty, you can do the metroplasty also. On this side also. Metroplasty, whatever pathologies you want to do, you can do. I think it is clear. Is it clear now?
Yes.
Now one by one, you both come here. Sure. He has brought the cannulation wire, so let me show you the cannulation thing. So again, you have to stay close here. Correct? And then introduce it. Look at my finger. Look at my finger. How my finger is supporting the light cable. And the camera is facing up. And now slowly I am putting the cannulation set here. Okay. It will go like this inside. This is how cannulation is done. Correct? And now you remove this wire inside. Take it out. Take this out. There is a stillet. No. Anti-clockwise. Whenever you want to take out something, anti-clockwise. Remember this thing. Clockwise it goes in. Take it out. Pull it. Understood? And then attach the syringe here and push the die. Introduce that into this and practice now here. You have to practice like this. Stay at the external os. See the endocervical canal completely. Go in, stay at the internal os, and now start examining the uterine cavity properly, every wall, and then close to the ostia, go here and do the cannulation. Okay? Chalo, come one by one. If you can explain this, it is better for you. Explain everything now. Chalo, you can explain. You can explain the arrangement here.
Always the camera should face up.
Correct.
And then the notch should be aligned to the endocervical canal while introducing.
Not endocervical canal. See, this whole thing is endocervical canal. The notch you want to attach to this opening. There will be small opening into the endocervical canal which is leading to the uterine cavity. Okay? Yes. So come back. Yes. First thing is examine the endocervical canal. There are sometimes polyps in the endocervical canal also. So if endocervical pathology, you have to examine the endocervical canal. Now slowly go in. While going in, you have to align the notch. Correct? Now you are properly aligning the notch to the opening. Go in slowly. Stay at the internal os. Correct? Now go slightly inside the uterine cavity and level up your hand. So that you see the panoramic view. Now this is the panoramic view. Anterior wall, posterior wall, fundus, left ostia, right ostia. Okay, go in now. Go inside. Yes. You are more close to the posterior wall. So stay like this. Okay, go here. Now if you want to see the left ostia, rotate the right cable to your left. You will see the left ostia, correct? But still left ostia is not visible properly. Yes. So you have to move the whole assembly towards the left. Now it is in the center. Correct? Now see the right ostia. No, not like this. You have to again move the right cable to the original position. Now take it to the opposite side. Come back. Yes. No, change your hand. Change your hand. Don't cross your hand. See, this is the position to see the right ostia. Now see the left ostia. You have to change your hand. No, change your hand. This is the understood. You have to change your hand. Otherwise, you will cross your hands like this. Don't do that. Got this? Sure. Now do the cannulation. Sure. How to hold? Now if you hold it like this, how do you do the cannulation? No. This hand hold here. Hold. Straighten the finger. Correct?
Yes.
Now your one hand is free. Now with one hand hold close to the void. You understood this?
Yes.
Huh? Go in. Go close to the ostia. Stay here. Stay here. Correct? Now there is no turn here. See, this is a mannequin, so you will get some difficulty here. But you understood,
Yes.
you got the idea
Yes.
of doing it, right? In the patient, it will be more easy. Now do the cannulation on opposite side. Opposite side. Change your hands. Correct. Now you want this hand to be free. So hold. Correct. Yeah. Go in. Yes. Okay. Easy.
Yes.
Is there any doubt in this? Now you practice, okay? On this mannequin, slowly practice. Don't damage the mannequin. What happens if you do it forcefully? You will damage it. So do it slowly, carefully. Don't break the scope. Don't break the camera. Be careful. So shall I go now? I have OPD patients. Is there any doubt you want to ask? No, nothing? Everything is clear?
Yes.
Okay, good. Chalo. Thank you.